let's keep this kind of patient-centric. Patient is now coming to one of you guys, and so what would be the appropriate clinical workup? So let me see if I can get back to Dr. Abraham, and he can walk us through maybe the clinical workup of a patient with tenosynovial giant cell tumor as he presents to your clinic.
Sure. I think the first thing to consider is really the history, because as I mentioned previously, there are a number of things that can present in a similar manner, and many of them are much more common than TGCT. So we take a good history, and I tend to look for those key words like my knee blows up, or I get swelling and I wasn't doing anything. I was standing there and my knee blew up. And I keep referring to knee because that's the most common site that we see. But this can occur in, really any joint, any synovial joint. So that is something that will always perk my ears up. And the chronicity or the recurrent nature, this happened 3 times last year, and then I remember it happened a few times the year before. So things like that will make me think along the lines of TGCT. If I don't hear those things and I don't have the feeling of that typical clinical picture, then I think it's important to start asking about other things. Does this happen in many joints? Do you have this? Does any of this run in your family? These are kind of things that may start pointing you towards something like rheumatoid arthritis, or have you been outside or been bitten by a tick, or things like Lyme disease. You start looking through the differential diagnoses, it's important to distinguish between these.
I mean, you're making a very important point that in this era of PET scans and next-gen sequencing, I think history and physical still is your best tool, if you will, to sort of get to the right diagnosis. And I think it's important that we emphasize that to our audience. But yeah, keep going.
Exactly. I mean, I think if I see one of the patients that ends up having TGCT, many times I will have a pretty good suspicion that that could be what's going on, just on the basis of history and physical examination. So I think that's really critical. And on physical exam, many times we'll see signs of a swollen joint. Usually doesn't have much of a look of an infected joint. There's no real diffuse erythema or anything like that, unless it's really very extensive disease that with extra articular component that could be seen through you can get a sense of it coming out through the joint. But the typical things we see will be a very swollen joint, hemarthrosis, or a knee full of fluid, which we would find later to be blood. And those are the kind of things that will lead you on to more further studies.
Imaging, what do you order?
Typically, we'll start with an X-ray, and that's just good orthopedic medicine. It's the cheapest study, but gives us a lot of information. You may see an effusion on the X-ray. You can see the joint space being expanded, but we can't see soft tissue, so we don't really know what's causing that. TGCT, when it has that nodularity, not necessarily nodular form, but nodularity even for the diffuse form, over time it can tend to grind down the bone. So you get these erosions in the bone, and that we can see on X-ray. And those are some of the things that make us start thinking about the need for more extensive surgery, like joint replacements and things like that. But we do look for things like erosions, which could indicate some more severe disease.
Is there a preferred cross-sectional imaging, and how would you biopsy and establish tissue diagnosis?
Sure. The preferred imaging modality is definitely the MRI. MRI gives us a good look at the soft tissue. Synovitis can be very well seen on MRI. The T2 or fluid-sensitive sequences can show fluid. We can see things like hemosiderin or blood products on T1 images. You can see things like blooming artifact. These are all some of the things that we look for on MRI. So again, even the combination of the history and then the physical examination and the imaging will give us a pretty good sense that this is potentially what's happening. In the past, prior to really knowing exactly what was causing TGCT or how, what the molecular details were, many times that alone would be an indication for going forward to surgery. So if you have a significant synovitis and we don't think there's another medical cause like rheumatoid arthritis or something like that, and we see some bone destruction, that's a problem that needs to be treated because we worry about the long-term effects of that. And usually that kind of situation will give severe pain and disability to the patient. So, in the past, there was really it wasn't really really necessary to do a biopsy because you knew the patient needed surgery anyway. Now I think the landscape has changed a little bit because we are more informed and we do know about the molecular basis, and we can better distinguish between other diseases that cause a massive synovitis like this. But really the important thing is with the introduction into the market of medical therapies for TGCT, it becomes very important to really know that we know what we're treating before we treat it with our medical therapies. So along those lines, synovial biopsy was previously never really appreciated to be something that worked well or could give a lot of information. And so we actually recently published a paper in skeletal radiology looking at the efficacy of synovial biopsy. And what we found is that we really could get the information we needed from doing a synovial biopsy. So these are typically needle biopsies. A small piece of the synovium is removed and we send it to pathology, and we can distinguish between the differential diagnosis of things we're looking for. So we see things, the pathologist will be looking for things like hemosiderin-laden macrophages, this very villonodular kind of appearance where the villi of the synovium become thickened, and some typical things that we can look for in PVNS.
So we will come back to the molecular aspects of the diagnosis a little bit later in the discussion also, but at this early stage in the patient's journey, do you as the orthopedic surgeon order any molecular testing, or is it an automatic thing that reference pathologists will do? How does it work in real life?
I don't necessarily order it right off the bat for every patient. I won't necessarily need it for every patient. I think with the combination of history and physical, imaging, and then an experienced pathologist, the vast majority of times we can make the diagnosis with that constellation of things, at least to the point of being able to go on to surgical treatment. If, for cases of recurrence, or if there's some question on the pathology or the surgical excision specimen shows something different, then we may start investigating the molecular diagnostics as well. But it's not something we routinely do.